welcome to Aina TV Health File. So we have today Dr. Ismail Panagunda with us, who is a family physician at a VA hospital. So our goal of Health File is to make sure that we have most important health conditions or diseases discussed by our specialists, so that they can give us some alerts or even make us aware of some of the questions that we might not be aware of when we go to see our own physician. So today we have Dr. Ismail Panagunda, like I said, and we'll talk about some of the most commonly seen diseases or conditions that we see in the United States, and how it also matters to us as Asian Indians. So when you see your patients, Dr. Panagunda, what are some of the most common conditions or diseases that we tend to see in Indian population or South Asian population?
Well, thank you. Thank you for inviting me to the show, and thank you to Aina TV. I work as a family physician. I think we should bring more and more, specialists down the line for the show. But to start with, every patient should have primary care. Primary care, what I mean is they should be going to their doctor once a year to check up their whether they have diabetes or hypertension, preventive services like how much high the cholesterol is, and also we need to also see that they can get preventive services for cancer prevention. Okay. Like if it's a female above 50, a mammogram, pap smear, all that stuff, which we'll discuss further. So the basic point I want to mention is every person who is above, even we go to pediatrics now, the issue is even the cholesterol is there in children. Yeah. We can arrest that high cholesterol even from childhood. So every person should go at least pay a visit to their doctor once a year. That's the first point I want to mention.
So what you're saying is we definitely need to make sure that we have a PCP or a family physician that we constantly go to on an annual basis, if not more frequently.
Exactly. If you need them in between, hope we don't, but if you need them, you can go and talk to them. But every year, I think that's the most important part. We, as I said, like Asian population who are NRIs here, miss, because we only go to the doctor when it is like emergencies, or when you have some bronchitis or whatnot. But regular checkups we often miss. Even I used to miss one time, but next year, because of the schedule, we don't think, hey, we need to go to the doctor and see. But if you make it in a habit of going like a dental checkup, eye checkup, and a regular doctor checkup once a year, that would go a long way.
I completely agree with you. So with that said, I wanted to make a note that a lot of the times we only go see a physician when it's emergent, which kind of leads me to think about hypertension. And it's people also call it a silent killer. And
Exactly.
Apparently, according to the CDC, that 1 out of 3 adults actually have hypertension, and 1 out of 5 adults don't even know that they're exposed to having an hypertension. So what are some of the things why does hypertension matter to us, first of all, and what are some of the things that we should be watching for?
I want to share a personal story. My grandfather, I was still a medical student, but he had a big stroke. My parents or teachers, they have enough knowledge, but not most of the knowledge, like health knowledge. So they didn't check his blood pressure, or he didn't go to the doctor for a while, I think. So he had a stroke which could be preventable, and he died with the stroke at the age of 85. But the thing is, if you don't control the blood pressure in our body, that is termed as hypertension, the pressure. So if you don't control that, in the long run, it can lead to heart attack, stroke, which is blood clot in the brain, or you can have a hemorrhage in the brain, and all other issues.
Kidneys, yes.
Kidney problems, yes. And so we have to check our blood pressure. If it is high, we need to make it under control. What I mean under control is there are 2 numbers. anytime you go check your blood pressure, normally it says 130 or 80. So 130 is called systolic blood pressure, and 80 is called diastolic blood pressure. So normally right now the recommendations are, if you don't have any problems, you need to keep it like 140 over 90. So 140 would be the systolic blood pressure, and then the 90 would be the diastolic blood pressure.
Is that something every individual should be checking at home with a machine, or should be? I know sometimes the pharmacies have a instant one that you can go and sit down and check your blood pressure.
Yeah, well, that's a very good question, because normally what we do is we also give a blood pressure machine to home to check by themselves. But to have a diagnosis of hypertension, we need to have like 3 readings.
Okay.
You know, you can do it at home, but you need to do the proper way.
Yeah.
So you can't just take it as needed. So the number one, if you want to do it at home, number one is you have to sit in a chair like this, and your feet should be touching the ground, and your hand should be supported, well supported, and you can put the hand, the cuff there, and start measuring it. And well, all of the blood pressure cuffs are calibrated, but sometimes it's good to have a regular manometer, what we do check in the hospital, to kind of calibrate it with the machines we use at home. So you take 3 blood pressure readings of that.
Does it have to be the same time?
Exactly, exactly. That would help, because preferably I would say in the morning when you wake up, and you can just check it, because over the time you're getting more stressed out, and you're running around, and caffeine intake and all that. So best time is when you wake up in the morning. Just sit down, check your blood pressure, and you can repeat that like every other day and see the 3 readings, and the average of the 3 readings, if it is higher than 140 over 90, then you have hypertension. And you do have like stages: stage 1, stage 2, stage 3. And if your blood pressure is like, if systolic, the top number is like 180 or more, and the diastolic is 100, 120 or more, then you are very high risk of hypertension. Very risk of strokes. So you need to immediately go to the doctor and get some help.
At a family of 5, maybe, mother, father, and 3 children, who should be checking their blood pressure daily or marking this? Are there some signs that tell me that, I'm dizzy every day, I have a headache every day? When do I know to start? What age should I be watching for my hypertensive or my blood pressure monitoring?
That's another good question. So basically, every individual, even for the kids, if they go to the doctor's office, they will check the blood pressure. That's called vitals. Vitals is your pulse. You check the pulse, your blood pressure, temperature, heart rate, and then your oxygen level. And so those are the vitals they check in the hospital. Every person, regardless of age, should get their blood pressure checked at least once a year. So that's one aspect of it. Now, some kids can get high blood pressure just by there are secondary causes of hypertension, like if they have a tumor, like adrenal, which is a gland, which is a hormonal gland. So, but it's very rare, but still you can check them. So you have to be checked. Now coming to the symptoms, you said, as you said before, it's a silent killer. So most often there will not be any symptoms. Sometimes some people say, they have this dizziness, or some people say, I think it's some spinning, but there are other causes of that, not definitely blood pressure, but they come to us with that reason. So most often there will not be any symptoms. But if the blood pressure is there long enough, untreated, they might get kidney problems, and because of the kidney problems, they might end up having shortness of breath. And for some reason, because of the fluid buildup, they can have swelling of their legs. So these are some of the things which, if the heart is affected and the heart goes into heart failure, as I said, they can't breathe. There is a swelling of the legs. But these are like extreme events, but most often blood pressure, for example, one of my patients said, hey, I can't see well, we sent him the eye doctor. So the eye doctor in the exam, they looked into the retina and said, hey, your retina, your blood vessels in the retina, they can examine. So because of that, they said, okay, you might have some blood pressure because your blood vessels doesn't look good. So then, that's how she had blood pressure. First she went to the eye doctor and then came to us because the eye doctor referred her. So those are some of the, sometimes we can catch them like that, but most often it is a silent disease.
It's a silent disease. So
Right.
some of the symptoms. So again, going back to your PCP on a annual checkups probably would help to see how
Exactly.
preventive.
Yes.
Because you can't. So because there are no presentable symptoms that you can identify and say if and then kind of situation, what age should I be more monitoring, and does gender matter? Do men get hypertensive exposure to hypertension more dominantly than women, or is it equally same?
Most of them are equal, if you, but it varies according to the age groups. So if you are normally if you're 30 and above, your blood vessels, get basically blood pressure is the resistance of the blood vessels. So your age is another factor. If you go on looking at the age 30, 40, 50s, so 40 years old have more chances of getting hypertension than 30-year-old, and 60-year-old actually. So if you're on the other end of the spectrum, like you're 40 plus, then your chances of having hypertension are more than who are below that age.
Is there a genetic also?
Exactly, genetic predisposition. Like if your parents have hypertension, you might be having certain risk of having more hypertension. That's how, if in your family, if you have more people who have hypertension, then you are at more risk than the general population.
Perfect. And does race or ethnicity matter in this case?
Exactly. African Americans are more prone to have high rates of hypertension than the general public. So that's where the race matters. And again, in the Asian population, we tend to have a lot of heart attacks and strokes than the general public in America.
Yeah.
So one of the reasons is untreated hypertension and diabetes in them too. So the race matters also. So we have to watch. And again, the propensity, there are certain factors like increased salt intake.
Yeah.
We like avakai, achar in the North Indians also, and then we used to tend to consume foods which are high in spicy content. Spice is good, but along with it you have ghee and more oil, salt, more salt intake, and these all together can drive your blood pressure high. So food as a part of the culture. Just not the race itself, but other things can also matter.
So diet matters, and exercise probably also
oh yeah,
matters.
Exactly. So if there are certain population, let's say obesity again, weight, if you have more weight, and if you're consuming salt and you don't exercise, the risk of you having hypertension goes up tremendously.
That's good to know.
Because of all these three things. So for example, for some people who are obese, they undergo surgery, right, for weight reduction. And once they undergo surgery and they reduce the weight, just by reducing their weight itself, their hypertension is gone. In a lot of my patients, that means weight plays a lot of role. So that's one thing. So you have to watch your weight and exercise at least minimum 30 minutes of walking every other day, not every day, should go a long way. 2,300 milligrams, if you can measure, we can measure that, but it's just a small amount. If you one time you can do it, you need salt for regular aspects of the
chemical
homeostasis. So you can't just stop salt. Some people advocate saltless food, totally saltless food, and I have seen some people drinking a lot of water, not taking any salt, and they go to hyponatremia. That means your sodium levels go down. If your sodium levels go down, then your brain kind of swells, and you might die even with that. But that's rare cases. But so we don't advocate no salt. You need to have salt, but in light proportions, like 2,300 milligrams per day, altogether, whatever salt you take in all the foods.
Since you brought up obesity, we'll also talk about obesity. Before going to obesity, I wanted to ask about hypotension. Does hypotension have also some of the signs, or is it something to be concerned about when we talk about hypertension?
Exactly. So hypotension is by itself not a disease. Like you have high blood pressure. People can have low blood pressure like let's say 80 by and they will be functioning normally. Certain people like athletics, they have low pulse, low blood pressure. I mean it's on the under lower levels. But hypotension mainly comes when people don't like I said, if you drink more water, there is another problem. If you don't drink water, then you get hypotension. So because your blood, in the blood volume drops. If your blood volume drops, your blood pressure drops. And again, hypotension is a sign of a disease, underlying disease. Like suppose if you have some infection, pharyngitis, and you don't treat it, it might get into septic shock. Septic shock is a thing where all your body's organs doesn't function and your blood pressure drops. So if your blood pressure drops suddenly, if it is normal, you need to get to the emergency room actually, to get some fluids and find out why your blood pressure is low. So, but for some other people, there is a thing called orthostatic hypotension. That's another thing, which is when you're sitting, you're good, and when you wake up, when you stand up suddenly, your blood pressure drops and you feel giddy or you fall down. So there are certain medications for it, also steroids you can use, and also there are certain things you have to stand up slowly, or any turning you have to do it. Don't do it abruptly, just do it slowly. But that's a very small amount of population who have that.
Any medications that that we should be asking our provider or PCP, like questions that we should be asking our PCPs when he prescribes our medication for hypertension?
Exactly. So there are a lot of medications for blood pressure. So normally they start with a fluid pill, what we call it's called hydrochlorothiazide. So what it does is it you will pee a lot initially, diuretic. So basically it reduces the blood volume a little bit by that and reduces the tension. So that's why that's the number one choice what they start with. But there are other things like beta blockers which control the heart rate and also down your blood pressure, ACE inhibitors which is act on the kidneys, because kidney is a special organ which controls all the blood pressure. So there are a lot of things, calcium channel blockers like amlodipine and all that. So it depends of your condition. Let's say if you have diabetes, ACE inhibitors are a good choice because it protects the kidneys. It is good for diabetic patients. And certain like if you have heart disease, then beta blocker is a good. So certain things like those. But any medication, when you go to the doctor and say, hey, you want to prescribe certain medication, you need to ask what are the side effects of it. What should I watch for if something happens, and then you need to tell them what medications you're taking. Like it doesn't matter, it's just prescription medication. Some people might be taking herbal medicines, and sometimes those can interact with them. And so you need to talk to them. So what I do is for all my patients, this is what I say when I see them first, because I don't know. Even though they say, hey, I'm taking this and this, I'll tell them, please bring all your medications, whatever you're taking, in a big box, whatever big it is, how much big it is or small, just throw them in there, bring it to me. How many times I see different kind of medication which they don't know, which is harming them, either harming them or not helping them, which they are taking. So that's the number one reason also. Sometimes the medications you take can cause diseases. So we need to streamline the medications, and also depending on what medications they're taking, we can prescribe another medicine for them.
So would you say for our viewers, if they're taking any medication, to maybe keep a running list of not only the medication name, the dose, the frequency that they're taking, and then the prescribed physician or whatnot? Is that
exactly. That's where the primary care physician comes in. Like if they go to a nephrologist or like a kidney specialist or a heart specialist or endocrinologist, and one prescribes one medication without knowing sometimes what they are on. So a primary care doctor has to, you will be the one who is the first step, reconcile them. That's exactly the word, medical reconciliation. That's what we said. So we need to have that list. What I do is once they bring them, I take off whatever medications if they're not needing it. For suppose if the cholesterol is very good and they don't have any other problems, then they don't need to be on a statin if they don't have any heart disease or anything like that. So I would just take off the medications which they don't need, and I'll give them a list like take it with you, keep it in your pocket. Whenever you see any doctor, you just show it to them. This is medications I'm taking. That goes a long way.
And that is a very valid point, because a lot of times we go to hospitals and sometimes there are emergency situations. We end up going to the ER or emergency room, and at that point, if you not only during the emergency care aspect of it, whether you're getting discharged, then in that case the medication reconciliation needs to happen at the discharge and the admission and at the discharge point. And at the same time, if you're getting admitted, that medication reconciliation still needs to occur during the admission point, admission point, and any transfers that need to happen at the level of care, and also at discharge. So these are very vital things that we need to actually give keep a track of, or have some running list with us, maybe in a wallet. So we talked about obesity, touched a little bit about obesity, which I'm thinking it also probably ties in with the diabetes as well.
Exactly.
And so do we want to talk about obesity?
Yeah. I mean, obesity right now, even in here, it's already a big problem, especially the childhood obesity. And even in India, like obesity before it wasn't a problem, now it is a big problem. So obesity is related to every disease. You name it: hypertension, diabetes, heart disease, stroke, everything. Just by reducing your weight, if they're above, let's say there is a thing called BMI. So body mass index. So you have to check that. You have to check your height and your weight. So how much your height weight ratio. So the number is 25. 25 or below is good. So 25 or above, you are obese. You are actually overweight, and then if it is nearer to 30, you can be termed as obese. So the only reason is just not what you eat. Some people might have that, there are hormones which act on your body, and even you have enough diet control, you can be obese too. So it's just not the diet. Diet is a big part of it, but there are other hormones in your body which, you have to check for thyroid, exactly. And then there is a ghrelin, there is another hormone secreted by the stomach, and which can play a big role, which is actually in the obesity surgeries. What they do is they do a gastric bypass. It's just not, the surgery is not just for the food, to take a little amount of the food. It's actually acting upon that, making that hormones imbalance correct. So those are the few things which are helpful. Now, definitely you need to have a medical help. It's just not you saying, hey, I can eat less and I'll be, I'll lose this much of weight. So it should be done under the medical care.
What is, so besides watching for our vital signs, it looks like BMI is also another question.
Exactly. That's what they do, because if you walk into the door, the first thing they check your height and weight every time, because they want to calculate the BMI. That is also one of the part of your physical checkup. Exactly.
So for diabetes, there's also a marker that you can look at when you're running tests, right?
A1C. It's called hemoglobin A1C. Basically, it's a protein which is on the blood cell, red blood cell. Hemoglobin is in the red blood cell. So this attaches to the sugar, and normally if you check your blood sugar once a while, you get like, hey, my blood sugar is 130 or 180, 200. That is called random blood sugar. You just check it, the sugar level, you'll know. But that is just one point of checking it
at that point.
But A1C, with A1C you can check what's the average blood sugar over the 3 months. So the average of 3 months random blood sugar, if you average it, you can get that number with that. So, and that's a pretty simple test, A1C, and if it is 6.5 or above, you have diabetes. So there's a new definition. Before they used to do like a 2-hour testing and all that. Even now it's recommended for some people, like pregnancy, like diabetes in pregnancy. But if you check that one single test, you'll know like, hey, where are you?
As a body.
And even for diabetics, we check that often every 3 months, because if it is 7 or below, they are in good control. But if they're 9 or 10, and we have to get it back to that number. So A1C is the one which is a number which is 7. That's what you have to remember. 6.5 is good. I mean 6.5 below, then you're kind of borderline. 5.6 or below, you're good. So, but if you're diabetic, it should be less than 7, closer to 6.5. But there are certain studies which are saying the number is not the main thing. You know, even if you, for some certain diabetics, if you bring them drastically below 7, the mortality, morbid rate increases. So they would say even if you're like 12 or something, you can be around 7.5. It's still good. You know, it's better than what it is. And for a certain population, keeping it a little higher than normal is also okay.
So our vital signs are BMI and A1C.
A1C.
These are some of the things that we need to keep in mind so that
Exactly.
we know our body as to whatever internal features are.
Yeah, I kind of like know your numbers.
Know your numbers.
Know your numbers. The health is in your hand. Like, you know, right now we have all the phones and smartphones, and you can even sometimes just put those things like in a regular basis, just in, you can graph it and see where you are. And apart from that, cholesterol is another one big number we need to watch out for, because if your total cholesterol is 200 or above and your LDL, which is a bad cholesterol, is 100 or above, you are at a higher risk of so it's better to be below those numbers for normal population.
So for our Indians or South Asians, we tend to eat a lot of rice. We tend to eat a lot of heavy carb food, and then heavy, I want to say maybe a lot of oil in our food, along with ghee, like you mentioned. So are these diabetes and cholesterol, are these some of those that we can actually control with diet, or if we have a genetic predisposition to them, are we fighting against something that we don't have any control of?
That's a very good question, very good point, because there is a thing called metabolic syndrome. Metabolic syndrome is, you know, overweight, and then you have high cholesterol, and then your risk for diabetes go up. And there is also a genetic predisposition to it, because we Indians, if you go back like few centuries or like few decades, for that matter, most of the you know, our forefathers, they have gone through certain period where they didn't have enough food. Actually, you know, like Bengal famine, and like lakhs of people died actually. So our bodies genetically, they tend to store the food in excess. Like for suppose if you eat and it get metabolized, right? But in certain people, it becomes more into fat stores, because as a genetical evolutionary point of view, if something famine like something comes, the fat can kick in and make some glucose. It can get through at least a certain time period. So that's called syndrome X. So basically, so that is a genetic predisposition in certain people, where even if you eat normal food, like let's say no salt, less vegetarian food, no extra fat, but still there are high chances of them getting a heart attack. Like a lot of our, particularly Indian population, around like 40, I have seen so many cases of this happening. This is because of the genetic predisposition. So that's where it comes in. The family history comes in. Like if their grandfather, their father had early heart attacks, then you can check with the doctor, and they can run some other tests to know. Like there is a thing called CRP, which is C-reactive protein. C-reactive protein tells us the inflammation or what's going on in the body. So that's one thing. And then you can do calcium scoring. Calcium scoring basically is a CAT scan of your heart, and then it looks at the blood vessels in your heart, and it gives us a score. And if your calcium score is high, then you're at a high risk of having heart attack. So you can do certain things like get a heart cath or something like that, or like a treadmill test, and get your heart checked out. So those are the certain things. But for particularly the Indian population, that exactly there is a certain number of patients, even though they did everything right,
I know,
you are still at risk. So that's where these things come in, like the knowledge of what happened with the heart attack. Some people say, my heart is burning. They think that even though they are having a heart attack, they tend to ignore those symptoms. Even though they have the pain, they said, it's okay, it's just heartburn. But eventually it might be a heart attack, especially in women. In females, there is these symptoms are very atypical. They don't. Normally, what are the heart attack signs? You get chest pain, mostly on the left side. You diaphoretic, and then the pain goes through your left arm. So these are the certain symptoms. But most of the patients don't typically present like that. Sometimes it will, the neck pain. It might be a heart attack, you know, if it goes above like this. Or sometimes some people complained, they have some earache or pain here, but eventually it turned out to be a heart attack, unfortunately. So how the pain came in and how much time it was there, these are the certain things. So basically, if you have something, uneasiness, and you haven't checked with your doctor for a while, just call that 911. And particularly for the stroke, like if you're when you're talking and you're slurred speech, and then you can't see, or your hand or feet get numb, or you can't move them, so immediately because there is a golden period, like a half an hour, where even you have a big stroke, with the sort of medications we have, you can actually be a normal person. Otherwise, if you cross that, you might have paralysis, and then for all your life you might suffer. So these are the certain symptoms you need to watch for that, you know, what we can say unfortunate thing. But if it happens, you need to call 911 immediately.
Apart from family history, social history probably also plays a big role,
yes,
right?
Yes, we didn't talk about that because
we talked about diet
and all
exercise.
That. Smoking, as I said, hypertension is the #1 cause for stroke, right? The next is the smoking. Actually, if you smoke, smoking goes for long list. Cancer, lung cancer, so any type of cancer for that matter, bladder cancer, lung cancer, colon cancer, everything. So smoking increases your chance of cancer. Smoking increases chance of heart attacks and strokes, particularly. So smoking is a big no-no. And coming to alcohol, anything in excess is bad. But they say red wine is okay once in a while, and if you keep it to a minimum, like let's say 2 drinks, not more than 2 drinks, not more than 2 times a week, it's kind of a fair amount, which doesn't cause any problems if you don't have any problems, you know.
And there's also a fine line with prescriptive painkillers too and medications, coming to again class 1 narcotics, obviously those are out of the picture, you're not supposed to do them, but illegal drugs. But even with medication, I see a little bit of I'm in pain, let me take extra dose to keep the pain down. So those are also some of the things to watch for. Just because it's prescribed, it doesn't mean
that's a very public message right now. It's actually the President Obama and Dr. Murthy, who is our Surgeon General, they are getting it to the public, because over the period of last 10-15 years, the deaths due to narcotic abuse, the prescription abuse, went up like this. And 40,000 deaths a year. That's too high. It's an epidemic actually. And more and more, I mean, as I said, in vital signs, for last few years we treated pain as a vital sign. That means you say, hey, you go to the hospital, they say, what's your pain from 0 to 10, and you are 8, then automatically you get something, morphine or something like that. But if you go with a chest pain or some shoulder pain, it's a fracture, you can get some narcotics and get some help initially, but not for regular chronic pain. Like if you have arthritis, you have to take some anti-inflammatory, but for mild arthritis, you shouldn't be taking a lot of narcotics, because narcotics are nothing but morphine or hydrocodone. They're opioids. They're called opioids, and they can depress your respiratory center. And most often, this is not happening in people who are getting prescribed medicine, because some people are addicted to it. They buy out, they buy outside, and share, and they take more, and that's how we should be very careful with that.
So that's part of the primary care as well. When it's prescribed, ask questions as to when am I supposed to take. Is it PRN, meaning has needed, or is it something that you should be taking until the course is finished?
And to add, we have to safeguard the medication also in this case, because the narcotics, if you get for any reason, for example, you have a surgery, they'll give some pills, but off late, like if you're a teenager, you don't know, like people they sell them.
Yeah.
Some people sell them, some people they'll take them, and so you have to be very careful where you put them safely with no access to anybody except you.
And the child-proof caps.
Child-proof caps also, yeah.
And not to mention, always ask questions. If I'm taking this medication, can I drink alcohol?
Yeah, exactly.
Right?
Any medication for that matter, but especially narcotics.
Okay.
So if you take them and you drive, some medications you shouldn't be driving also, certain medications.
So deviating a little bit from our medication, because we've kind of touched about how to not only ask questions, but at the same time, what are some of the tests, the lab tests that we should be asking our physician, or even be making ourselves aware of. Next thing I wanted to ask you was about thyroid, TSH.
Mm-hmm.
Is that something that's done only for female? Because I hear, or for male, both.
It's not included in your regular, checkup. Like it's not a mandatory checking for everyone.
Mm-hmm.
It depends on your symptoms. Sometimes fatigue, like you're getting tired, so soon in the day, and then your weight gain, as I mentioned. So certain things, and your puffiness in the face. So all these symptoms, they're hypothyroid symptoms. So that means your thyroid either is low, then you can have it. Or if your thyroid is high, you have palpitations. So somebody who have like the heartbeat is like more than like 100 or something all the time, and they're jittery, anxiety, and so you need to check thyroid for them. So it's not a regularly mandated test, but some doctors just check it for everyone, but they will check it accordingly. So thyroid, TSH is one to check for that.
So if you were a normal person, if I was a normal person, and all of a sudden I'm feeling a lot of lethargy and tiredness, if I see difference in my own self from the baseline, then that's when I
Exactly. Even if you're like some depression, and so certain medical problems like hypothyroid can cause depression.
Okay.
So it's just not like the depression, you have something, it fell on you. It's just a medical condition which is doing that. So if you treat thyroid, it might get better. So so those things.
I have one other question. I think a lot of our South Asian population or even Indians get affected a lot by this anemia, and especially in women.
Yes.
And so what are some of the things that rather than saying, back then they used to say third developed or developing countries have anemia and it was okay. So there's baseline obviously for your hemoglobin level.
Yes.
And what are some of the dietary supplements or diets that we can use to make sure that we don't tip over to the left side of our anemia?
Sure. Anemia is a big problem, like in, as you said, in India and Bangladesh and all that. So girls who are like, like 14, 16, if you check them, so while I was working in India, like a government doctor, I have seen people like kids with hemoglobin of 6 or 7.
Yeah.
And that means you have to give them blood transfusion, actually, because they're always complaining fatigue, and the heart rate is high, and normally they don't go to the doctor. So when we go for regular checkups, we find so many people with that. So basically anemia, number one is if you take low iron, like food, because there it is the iron, low iron. And again, with the girls, you have the menses and you lose blood, and so that's another part of it. So either you make less blood or you lose blood.
Okay.
Those are the main two things.
Okay.
So for example, if it's a young girl, if she's not eating well, or if she's losing more blood because of the menstruation, then she's at a high risk of anemia. Now if you take an older person, like a 60-year-old, then if it's a 60-year-old female, then that's a red flag again, because she might be losing blood without the knowledge from the colon. They might have colon cancer. So a lot of people like a 60-year-old lady came in just for a regular checkup. His blood count was very low. So the normal hemoglobin for adults is like 14 to 15 for males. For females, it's 12 to 13 to 14 or something like that. So if it is below that level, you need to act. So do some tests, check their iron levels. If they're normal, check the stool test. There is a stool test where if guac test, where they check for any blood loss in the stool. If there is a blood loss, they do a colonoscopy. here comes, we'll talk about the prevention of cancer later, but that's another thing. So they might be having another cancer where they're losing the blood and having this issue. And there are other issues depending, as I said, race, and there are other anemias where in African American population there are hemoglobinopathies where the blood cells, are not formed, like thalassemia well enough, sickle cell where the blood cells will break and they go into anemic crisis and severe pains and all that. So there are a lot of a huge topic. So as I said, these all things we need to going on forward, we'll bring the specialists like hematologist and oncologist also to actually discuss each type of anemia. Like for example, iron deficiency anemia, what you need to do, and then as I said, hemolytic anemia, what you need to do, and thalassemias, what you need to do, like that.
So we definitely need to make sure in our list that we were, like you said, know your numbers.
Yes.
And your hemoglobin number should also be part of your
regular checkup. They will check that one out.
So if you don't mind, just one time finalize to our viewers the high points of what you hit, say what needs to be in their know your numbers list.
Okay, exactly. So write down if you have to. So when you go to check your, automatically if you go to your primary care doctor, they will check all these things. But if you write them down and then make a tick list, checklist, you will have all the numbers with you. So number one, as I said, is your blood pressure, vitals. Like your pulse rate, as I said, normal, anywhere between 60 to 100 is normal, depending upon your things. Sometimes there will be a little lower also. So pulse rate, blood pressure, so pulse rate 60 to 100. Sometimes it can go up. Ideal number is 80. Now blood pressure is, right now we say if you're a healthy adult, 140 over 90, below that is okay. Now, if you're diabetic, it should be around below 130 over 80. 130 over 80. And then A1C, hemoglobin A1C. So 6.5 below. Actually, ideal number is 5.6 or something like that. But if it's 6.5 below, you're not diabetic. So you know that. So every year you check that, you know that you're not diabetic. If you're diabetic, you should be below 7 of that number. And then high cholesterol, the total cholesterol should be less than 200, and bad cholesterol, LDL, should be less than 100. But if you have a heart attack or diabetes, your LDL, the lower is better, like less than 70 is better. So that's where the statins and all comes in. And your HDL, which is a high density lipoprotein, which is called good cholesterol, it should be high. Normal is 40. If you're 40, you're well and good. But exercise, running, it can improve that a number a little bit higher. So your good cholesterol is good for your heart. So that is should be 40 or above. Bad cholesterol 100 or below. Total cholesterol 200 or below. So those are the numbers. Again, hemoglobin, as I said, 14. Anything if you're adult male, 14 is a good number, and then adult female 13 is a good number. So those are the few things.
And along with your medication list.
Exactly.
And then allergies.
Allergies, we didn't touch on that because what happens is sometimes if you don't, like for example, we talked about ACE inhibitors in diabetics or hypertension, but that can cause cough. So if you know that, side effects or whatever is happening, if they prescribe a new drug and then you are having cough, you can know, hey, doctor said this cough is coming, so you can go back and check with them. So those are certain things. So and then if you're allergic to some medication, it can cross-react with others, like sulfur drugs or penicillin. So other drugs also can cross-react to that. So you have to be making sure what allergies you have, what medications you're on, have a list with that, and what number, where you are on that spectrum.
Well, thank you so much for this valuable information. And then we'll come back and then touch on each one of these topics for the prevention care. And we all also bring in like the specialist and talk about each topic in a wider, because we just touch the numbers and on the periphery, but we'll go deeper and then talk about. And also we'll invite our viewers to send us some questions. So we can answer them from the specialists also. And I thank Paramla Garu for this wonderful interview and opportunity, and then Balu Garu from Aina TV for making this happen. Thank you. Thank you. And What we'll do is we'll keep bringing you back to Aina TV, as our Aina TV is a primary care physician, so you can guide us as to which specialist to go to for certain type of symptoms or conditions,
Sure.
and then get your knowledge from there. Thank you so much. If you have any questions, please do send us in so we can ask those to our specialists and get the proper answer for you. Thank you for watching Aina TV's Health File. My name is Parimala, and we had Dr. Ismail Penagonda with us, who is a primary care physician at a VA hospital.
Thank you.